Good morning from Miami Beach. This is Dr. John Bennett of Neurosurgical TV. We have the honor of hosting Orlando Del Maestro, MD, a neurosurgeon with a very interesting background in not only medicine, but the arts. But today he's going to be talking about neurosurgical simulation and artificial intelligence learning center that he's the head of in Montreal. Okay, very good, Orlando. Welcome, and it's all yours.
Thanks everyone for coming on the Zoom. I particularly like to thank John Bennett for allowing me to provide some information about the types of research that we're doing at the present time. Now I'm going to share my screen now, and can everybody see my screen?
Yes, yes.
Okay.
Perfect.
Well,
perfect.
Give me a second here. All right. So my topic for today is just going to be a small number of slides. Is really using immersive learning, virtual reality, and artificial intelligence to improve surgical performance. And I'm going to talk to you a little bit about intelligent tutoring systems. So our vision in our laboratory is the globalization of safe surgery through the utilization of simulation artificial intelligence. And predominantly what we deal with is immersive learning. Immersive learning is learning that puts individuals in an interactive learning environment. It can be physical or virtual to replicate possible scenarios or to teach particular skills and techniques. And it can involve role-playing virtual learning environments. They're all considered parts of this immersive learning situation. Now, the questions that we're interested in asking are, what are the composites of technical surgical expertise? In other words, what are the components that make up surgical expertise? Next question is, what are the best techniques for teaching these composites? And is there a role for intelligent tutoring systems powered by artificial intelligence? Now our center is made up of 4 particular groups. There are neurosurgeons, orthopedic surgeons, various individuals involved in research, and a clinical surgical knowledge group. There's an educational group. We have particularly Olympic sports psychologists involved in that group to help us with some of the issues associated with education at highest levels of performance. We have a whole group involving computer science, and other groups involving clinical trials experience. So what do we really want to do? Well, our goal is to improve surgical expertise. So we learn a little bit about surgery while we're in medical school. The vast majority of the learning occurs during our residency, some after during our fellowship. And then we have a period of time where we continue to learn to reach our peak surgical performance. It's difficult to know what peak surgical performance is in an individual person, but it probably occurs somewhere between the ages of 45 and 50 if we base ourselves on, let's say, the airplane industry, and then we stay there for a period of time. So what would we like to do? Well, basically what we'd like to do is move this curve to the left as far as possible so that you learn more during your residency, more during your fellowship, you reach a surgical performance sooner. And in essence, what we're doing is moving this curve as far as we can to the left. So how does simulation help us? Well, it can give us a quantitative assessment of what expertise really is. In other words, how do experts actually do the procedure? How important are tactile, visual, cognitive components? Really getting at the question of what actually is expertise as far as neurosurgery is concerned. The second question is, how do we prevent error? How do we understand why errors occur, and can we understand how to prevent them? We also want to understand, how do we use education theory, modern education theory, like what is the role of the teacher, repetition, rehearsal? How do we implement all those things to make teaching better? And can we use simulation to select individuals to go into neurosurgery, to teach them and to retrain them if that has to be done? So to do this, we basically have developed an arc of improving, with the goal of improving surgical expertise in simulation and artificial intelligence. We have to build simulators which have the appropriate tactile and visual reality. We have to do research on these simulators. We have to validate the metrics on these simulators, and we have to determine whether these simulators actually improve surgical output performance. So this is one particular simulator that we developed, which is called NeuroVR. And this gives you a little bit of an idea of what it's like. You have virtual instruments. The brain pulsates. We've put haptics into the system so that you actually feel what's happening. And here it's a completely virtual operation. And we have developed very, very good simulations. Here's a subpial resection, for example, that's been done in a human. And here's what it looks like in the simulation. The individual gets the feeling, you can see how the brain responds, you can see how the age. And we've put a fair amount of work into developing these very accurate simulations. We also developed an anterior cervical discectomy infusion and spine simulator, and we're developing 2 other simulators at the present time for spine research. So the real issue is, how do we deal with this idea of quantitation of expert performance? Well, you have to develop metrics. Metrics are really, how do you quantitate it? Well, you quantitate it with metrics, and metrics are standards of reference where you can assess performance, efficiency, and assess progress. But the most important question is, what are the important teachable metrics? What do we really want to teach the student while they're doing their particular procedure? We've carried out a series of research projects and basically looked at safety metrics, the quality of the operation metrics, efficiency metrics, and also how you use your bimanual cognitive experience to develop your expertise. And for example, at the present time, we can identify every single movement that a surgeon performs during a virtual reality procedure. Every force, every acceleration, every deceleration, over 5,000 metrics can be identified during your removal of virtual reality performance. Here you can see, for example, we're using force. Medical students, for example, use too much force during the removal of tumors. It decreases when you become a junior resident, less again when you become a senior resident, and neurosurgeons, generally speaking, use much less force than other trainees. They tend to modulate their forces that they use after they graduate. We can also develop curriculum in which you train individuals to use their dominant hand, both their hands together, on subfield practice scenarios, for example, and then on very, very complex scenarios afterwards. We developed a virtual reality neurosurgical performance model. And in essence, in all the simulations that we do, experts focus on 2 things. They focus on safety of the procedure and the efficiency of the procedure. And we can also provide the learner with immediate feedback. We can provide them, for example, with feedback on what they have done during the procedure. Have they used too much force, et cetera, et cetera. We can show them all the forces that they've used during the procedure and where those forces are being applied, for example. Why have we used artificial intelligence? Well, the first experiments were based on what surgeons felt were the most important metrics, but artificial intelligence can provide you with more metrics. What is artificial intelligence? Well, it really is a branch of computer science dealing with simulation of intelligent behavior in computers. There are certain groups, for example, there is what is called machine learning, which are basically equations or algorithms, which can identify various methods of differentiating groups. There's what are called neural networks, and I'll talk about that just a little bit, and deep learning, which I won't talk about too much, but we're doing experiments with deep learning now. So what do you do with these simple classifiers? Well, what you basically do is you define a group, and then you decide, well, you have experts. You then use a particular algorithm to differentiate, let's say, experts from non-experts. And then you bring in a new person and decide whether or not that new person is an expert or not. For example, you would have individuals do a simulation. You tell the machine, these are experts, these are not experts, for example, residents. The machine then decides how to differentiate the two groups. And then you bring a new person into the group, and that machine then tells you that person is an expert or that person is a non-expert related to that particular set of metrics. And we had published a series of papers related to machine learning, identification of surgical and operative factors associated with surgical expertise. But then the next question that we answered, yeah, now we know that these particular metrics are important, but which metric is most important? And to do this, you can use what are called artificial neural networks. And artificial neural networks are really computing systems inspired by biological neural networks. So basically what they are is a collection of units or nodes. And these particular systems actually are loosely modeled on the neurons that are present in the biological brain. And the real importance of this, and I can't emphasize this more if you're going to involve in this at all, is it actually tells you which metric is most important. For example, while doing, for example, anterior cervical discectomy infusion, the machines will tell you, for example, that there are safety metrics. For example, how many times you touch the dura with your instruments is an important safety metric. How much force you're using. They provide, for example, motion types of metrics, how you accelerate and decelerate an instrument, and your efficiency metrics, how quickly you're able to do things. But we don't know which one of these we should actually teach. We've got 16 here. Which one do you actually teach? Using artificial neural networks, you can basically work out, for example, if you look at the first 4 important metrics in ranking, 3 of the 4 happen to deal with safety, number of contracts with the dura, the tool that you're using, for example, the force that you're placing. And these make up around, let's say, 50–60% of all the particular metrics that are associated with actually teaching how to do an anterior cervical discectomy infusion. The next thing, I'm just going to go through this you can develop a machine, and we're testing these machines now, which are called intelligent tutors. So what they actually do is replace the teacher in the operating room. And basically what they do is you do a particular procedure, a virtual reality procedure. The machine then tells you you are a novice. It tells you why you're a novice, and it tells you what you have to improve to get better. And it will not let you go on in the simulation until you get better, to get to a point where you're actually safe to do the procedure. And after you're safe to do the procedure, the machine will allow you to go on and do the other portions of the procedure, for example, to teach you how to be more efficient in other aspects of it. The next thing we've done is really look at what happens during the whole procedure. In other words, here's, for example, an individual doing a procedure, suddenly will make a mistake and will cause bleeding to occur. So that individual is working at an expert level for a lot of the procedure and suddenly makes a mistake. And therefore, as soon as you make a mistake, you move from being an expert to being less of an expert from that point of view. The other thing that we've worked on is intelligent machines. What is a future operating room? Are we going to be assessed by which forces we're using during a particular procedure? And are we going to be able to get information about the propensity? If you're doing a particular procedure in a particular way, the machine can warn you and say there's a high likelihood that you could cause an error and therefore modulate your behavior. And so if we're going to globalize these intelligent machines, like has been done, for example, in the airplane industry, we do have scenarios that are realistic. We have various ways of understanding how to teach those scenarios. We are emphasizing patient safety. We have multiple levels of validation. We've developed benchmarks, which we can sort of get an idea of why you're an expert. We have different ways of training. However, what we haven't done is been able to really validate these systems and really show that they improve surgical performance. Those experiments are underway. So just to finish off, Leonardo da Vinci said that it was a mediocre pupil who does not exceed his masters. I think another way of looking at this is we can say that it is a mediocre teacher whose pupils do not exceed him or her. So the idea in the future is really to develop systems which actually are really a combination of the human ability to teach and the machine's ability to understand teaching at a higher level, and then understand what is happening during these particular operative procedures to improve surgical performance. So questions that are always asked in these situations is, will computers replace clinicians? And the other question is, will computers replace surgical educators? The answer to both these questions, of course, is no. But the important thing is, how do we use these computers to help us train our students, our learners, to reach a level of expertise that is, let's say, continually improving, and also a level of expertise that decreases the risk of error during operative procedures. So there's a huge group of individuals that have been involved in helping us do these procedures. If you're interested in these particular issues, we have a website, and the website has all our papers. You can look at all our papers, download all our papers, and see all the types of different things that we're doing on a regular basis. We also have Friday forums, and our Friday forums are attended by individuals from all over the world. And we, through these Friday forums, initiate various research projects and help each other develop better technology related to developing artificial intelligence. And this is some of the group, for example, we call it a machine learning hive. So that's a little bit long, but I thought it would be important for you to sort of at least get to know what we're doing at this particular time period. And so you can see a little bit of where the future is going. I'm completely convinced that in the next 5 to 10 years, the neurosurgical operating room is going to be completely different than what we have at the present time. It's going to have multiple smart instruments. It's going to have instruments that are able to tell you how much force you're using during an operative procedure, what the possibilities are that you could cause an error, for example, and it's going to watch your performance in a way that happens, for example, in a airplane cockpit. For example, most major airplanes do not need a pilot at all. They run completely on artificial intelligence system. Why you need a pilot if something goes wrong, and then the pilot will take over. So the interoperative environment will not be in that complex way, but it will move slowly to the idea that we need smart instruments in the operating room to help the surgeon do the best possible job to carry out a particular procedure. So that's where we're going at the present time. And I'm open for all questions.
Okay, Dr. Del Marcio, thank you very much. And it's very lucky that you're talking about this relatively new area, neurosurgery. We have a neurosurgeon here that's very digitally smart, and he is taking over at a trauma center in India. And I'd like to have him lead the discussion. Very digitally smart. Ipe, you there?
Yeah. John, it's almost a month that I have not been tuning in for meetings. just out of pure boredom. We've done a lot of webinars and stuff, but I wanted to see this. And Rolando, I mean, can I ask you a few things, Rolando?
Sure, as many questions as you like.
First thing, you know, for the last 4 years, all my fellows and my colleagues will know, they used to call me crazy, but after seeing Garnet Sutherland, I don't know whether you know Garnet. Garnet has been a good friend for over 10 plus years. And after—
I trained Garnet. Garnet was one of my students.
Oh, great.
I see. So Garnet was a very close friend. So he's visited me 3 times. When I was in Nepal, he visited me 3 times. And the last time I was in Biratnagar before I moved to India, he was there too. Now it's a small world. So I always thought, when you told me, your last sentence about the next 5 years being completely different, I completely believe that too, because it is after Yasagil and the era of microscope, there's not been a paradigm shift in neurosurgery for maybe 50 years. You can attribute a lot of things to it. I mean, I attribute paper writing to it. All the researchers getting into neurosurgery, the ones who doesn't worship surgical skills as such. But that's not the only thing. The main thing has been the software and the hardware which we could use. For example, right now, navigation is a different screen. The microscope is a different screen. And, the neurophysiology is a different screen. All this could be put together. This is what I am working on right now. So I believe if sometime we could talk, maybe not in a webinar, but if you're open, I would be very, very proud and honored. I mean, especially since I know that you train Garnet, if we could talk sometime, I mean, maybe if John can arrange, and if you have the time, I'd be very happy to talk to you about the projects that we're doing, and maybe I can have some advice from you.
Sure, I think that I agree with you. If you look at the airline industry, in the 1960s, early 70s, they implemented what are called systems to identify particular issues associated with navigation. How far you are from the ground, all these other sort of technical abilities. We have those technical abilities in the upper room. We measure heart rate, temperature. We can do operations under neuroleptic anesthesia. We can get all this data. The next thing they implemented was simulation. And simulation in the airplane industry came in the 70s. And we have yet to really implement simulation in the neurosurgical operating and in 2020s. The first thing that happened with the implementation of simulation is the number of errors in the airplane industry went down spectacularly. So if you look at that model, what they've been able to do is work with the warning systems, simulation, and they've worked a lot on working with people together, what's called the human factor. How do people in the operating room deal with an error? Or how do people in the operating room deal if something goes wrong? So they've moved along in that area very, very quickly. The second thing that's happened in sports in particular, we have Olympic trainers in our group. It's interesting, Olympic trainers do not expect individuals to be competent. They expect people to be expert at their performance. In our world, in neurosurgery, we talk about competence, and in surgery, we talk about you being competent. Well, what is competency? How many errors do you produce, or do you deal with if you're competent? I think we should remove the idea of competence. We should only deal with the idea of expertise and expert in neurosurgery. We want all our students to be better than we are. That would be the goal. How do we get our students to actually get to be better than we are? And to do that, I think we have to work on these new systems in the operating room. And the more we do it, the better. You know, the more we interact with each other across the world, from my perspective, the quicker this is going to happen. Because virtual reality can be used on a simple computer in front of you, for example. It allows everybody to have access to these very high levels of let's say, machine learning algorithms in other particular areas. The second thing that I'm just going to go on here for a second. The second thing that we've done, if we looked at our machines better than surgical educators at training individuals to do a particular procedure. And our initial experiments suggest that these intelligent tutoring systems are as good as surgical educators. And in some situations better, because they know exactly why you're not doing a particular procedure well. For example, if you look at a particular procedure, let's say removal of a brain tumor or an anterior cervical discectomy infusion, you know, the student is not bad at all components of that procedure. The student may only have one or two areas that they're not very good at. And if you can identify that particular problem early and deal with it very early, you can remove that particular sort of problem from the student's sort of behavioral, sort of surgical script that they have in their brain, and deal with exactly how that individual is doing an operation. If they're doing it well with no problems, well, you just go on to the next operation. If you're not doing it well, why are you not doing it well? Can we identify that, improve that particular problem right away? So those are the types of things that we're looking at.
Rolando, if you would be willing, I would like to take some time of yours later on. Maybe I can ask some questions, because these would involve me disclosing things which I am working with in some projects. So maybe I cannot do this on a webinar. So if you have some time, I would like to speak with you. Maybe John can arrange it, or we can mail each other. I'll probably get your mail from John, and then if you have some time, then we can have a meeting together. Maybe John, do you think will it be possible for you to arrange, if Rolando had some time, we could sit together with him, so that
sure, we'll talk after the conference and set something up for sure.
Right.
I'm more than willing to work with anybody that is interested in these particular areas. You know, for example, to be honest with you, one of the individuals who's working a lot in our group is from Iran. And, you know, we have huge numbers of individuals from, you know, many individuals from around the world. Artificial intelligence is not a Western, in any way, shape, or form, technology. You know, these are very relative. If you have my suggestion, if you're interested in these types of things, what you should do is think about picking out an intelligent resident who has these types of skills and get them involved in these types of areas. Because I believe we should lead, neurosurgery should lead this charge into artificial intelligence, and using artificial intelligence and all the ability it has to improve neurosurgical outcomes. And the only way we can do that is to train our young people to do it. And to do that, we have to train them well. And we have to also lead the situation of developing new machines, be involved in the patents that are associated with developing these machines, being involved in the technology and the work. That can only help countries. You know, you're helped if you have these types of ideas and concepts in front of you that you can help develop. Other questions? There has to be some other questions.
Yeah, we have a bunch of questions. I think Manuel Encarnacion, a neurosurgeon from Russia. Are you there, Manuel?
Yes, I'm here.
Go ahead, Manuel.
Yes. First, thank you for your speech, and congratulate you for your work. Okay, I have some question. Because, for example, I tried the Neurotouch. I tried in Russia, but you know, something I figured out a long time ago is surgery. All kind of surgery. It doesn't matter. Is general surgery, neurosurgery, vascular. Is 70% anatomy and 30% is how to deal with the tissues, to see and know how to work with different kinds. But something the simulator never give is sensation. Because I tried the Neurotouch, yes, it's very good, but I don't have any sensation because all what I do since the craniotomy, dura opening, I don't have sensation. And you know how the residents gonna have skills working with tissues if they don't know how is their feeling, because that's a problem. Because in the simulator you can be doing an aneurysma, but you don't have sensation. So in the simulator, you can open the dura in the same, because you don't have sensation, you want to open the dura in the same way you open the arachnoid. I'm telling you because I am working with the simulator. I'm working with simulator, and the stone in my shoes is to find the right sensation. Because otherwise, if you put me the simulation, I can put the simulation to first-year residents, and they can perform anything. But when they get to the patient, they're gonna treat the tissues like that because they don't have the motor skills. And for that, we have a learning curve doing, for example, with the rats, to feeling how to dissect the vena cava and the aorta in the rats, because this sensation is something very important in surgery, in all surgery skills. So if you can explain me how we can get sensation in virtual reality.
Well, what I can tell you is that the simulator that you have, whether you've used the one that presently is in UFA or another center, it's a prototype that was developed probably about 8 or 10 years ago. And the CAE, which has put forward that particular and sells that particular simulator at the present time, hasn't integrated all the information that presently is available. For example, what I did in the new simulations that you just saw there is we actually measured what the actual density of tumors were in real life. In other words, in real life, in the operating room, what are the densities of tumors? And then we put all that information into the newer simulations that we have at the present time. So Manuel, if you would do a simulation involving some of the complex models that we have at the present time, you would see that there is a difference. The second thing is the simulators that are out there do not allow you to change the actual forces. In other words, what the feeling is of the tumor. We have prototypes. We can change the color, the amount of, we can change all aspects of it. For example, we can change how much density the white matter has compared to the gray matter, et cetera, et cetera. So our simulators are built on a system where we have the ability to adapt them to be as close as possible to what the real feelings are like. And if there's been a paper just produced, for example, in the World Neurosurgery from Dr. Sabah from Jeddah, who worked in our lab, and you can see how we've developed these simulators, the newer simulations, to be closer to reality. Are they perfect? Absolutely not. They need more work, but the only way they need more work is to have more engineers, more people who have these skills to help develop these particular simulations. What I can tell you now is, for example, on spine simulation, the spine simulators are getting better and better because they can develop bone simulation a little bit easier than we can develop. For example, the nuances that are involved, for example, in differentiating the edge of a tumor compared to white matter or edematous white matter. So all those things have to be involved. We are at the very beginning. If you think about what we're doing now and think of what, there is no limit to what you can do in the future. All it involves is developing systems where you just change the feeling. If you don't like that feeling because you don't feel that feeling is proper, you should be able to change it to what you feel is the feeling that you get when you remove, let's say, a low grade or a high grade glioma from that aspect of it. Because clearly one of the big things that we found in our early experiments is that residents still depend a lot on color to differentiate where a tumor is. But an expert is mostly depending on the haptic feel of, let's say, a glioma. So there's a difference between experts and non-experts as what they actually feel.
We have one question, Doctor, from Ashraf. Go ahead, Ashraf.
John, sorry.
Go ahead, Manuel.
Because my intention is not, don't try to, you understand, it's very important what you're doing, but also, I'm telling you because I tried the Neurotouch in 2020 in Russia. I tried, and also it's important with the price. Because I know the price is not, it's something we're not gonna talk about but the price is high. And if we try to teach the resident and the department, it's not a product it can be used in third world countries because the product expensive, it's not rentable. Because as I'm telling you, if we don't have the sensation in spinal models, if we don't have the spinal, and when you put the screw, you feel, it's gonna be very hard. It's gonna be very hard for the learning curve for the doctors. Because, for example, if we don't feel the glioma, if we don't have the sensation of the glioma, and we cannot, because in the simulation, we can remove the glioma and the meningioma very, very fast, very quick. But if we don't have something similar to the sensation, when we go to the patient, we're gonna try to remove the glioma like a meningioma, or because we don't know the sensation, and it's a very important issue.
I agree. I think the only thing I can tell you is that it is a problem that is solvable, and we have already solved it. At least partially solved it with our new simulations. It's just a matter of engineering. It's just a matter of engineering. There's no magic to it. It's just a matter of engineering and putting the engineers to work on having a simulation that has a feeling that you want, Emmanuel. And if you get the engineers to do that, it will be available to you. The cost, the price, of course, is an issue. There's no question about that. And but when you think about how much it costs to buy, for example, a high-end microscope, you know, we're dealing with expensive costs there too. The other potential is obviously there are going to be cheaper systems on the market. But if you look at the airplane industry, they do not go cheap. They don't go for cheap simulations. They go for the most accurate simulation they can possibly have. So you actually feel everything.
Yes, so, but remember, we work with feelings. We need to feel. It's something important.
I say, Manuel, come to the Neurosurgical Simulation and Artificial Intelligence Learning Center, and you'll be amazed. You'll be amazed.
He will come. He will come. He's been to Russia, Dominican Republic, and he'll go to Canada too.
No, absolutely.
Go ahead.
Okay, we have some more comments and questions from the panel. Go ahead and step up, panelists, and ask your question. Amir had one, and Ashraf had one. Go ahead and ask it now. Go ahead.
Yes. Hello. Thank you, Dr. Maestro. The idea is really fascinating. But is there any statistically significant evidence that shows these simulators actually do make a difference in neurosurgical training or not?
At the present time, there are two issues associated with that. One is that the problem a little bit is that neurosurgery procedures, for example, on gliomas, are not completely standard. So for example, if we had a situation where every single operation that you did in the upper room was exactly the same, then you can do a controlled trial. So what we are involved in doing, for example, is training half of the individuals, half of the residents on this simulator, not training the other half on the simulator, and then having them do ex vivo brain simulations where we can do pre-op and post-op 7 Tesla MR scans, for example. Now we have technology to do all this. So we're trying to answer the question as best we can at the present time. I think that there is substantial evidence that will be available to give us more insight into that particular problem. It's clear, for example, if you do abdominal surgery, that every abdominal surgeon now has to be trained on a simulator in North America before they can do any type of abdominal surgery. For example, cholecystectomy, et cetera. So that's part of the training. We are not at that point yet, neurosurgery. But I think that the orthopedic individuals may get closer because their operations are so standard. They may be able to move more quickly than we can, for example, related to that. But we have to develop sort of a hybrid model so that we don't, we train people on the simulator, don't train half the people on the simulator, and then see how they do in these hybrid, very, very, let's say, standardized models, rather than training them on, for example, trying to deal with the problem of how complex neurosurgery may be in that particular tumor. Because what happens is, you do not know when you look at an MR scan, is it going to be vascular? Is it not going to be vascular? Is it going to be very easy? Is it not going to be very easy? So how do we deal with that complexity when you're training, let's say when you're randomly deciding to train half your residents and not half the residents? We have to have some type of a hybrid model that doesn't risk the patient, for example, initially in that situation. It will come, but it's going to take a little bit more time.
If I may, a second very quick comment. I've got into working on one of these simulators using differential pressure membranes to simulate the actual ventricular puncture, the tactile feedback when you do the ventricular puncture. It's based on artificial intelligence mixed with some sort of robotic technology. Do you think this kind of technology is going to take us somewhere in actually training our residents or not?
I think the only real way I can answer that is to do a controlled, randomized trial to see whether or not it is useful. One of the issues that we have a little bit, for example, if you take the Montreal Neurological Institute and Hospital, we have about 15 neurosurgical residents in various levels of training over the 6 years, for example. Then you end up with 2 or 3 residents in each year. The numbers are small. The advantage the airplane industry has is that every time a plane goes up and comes down, they download all that information. So they literally have information on millions and millions of flights. And therefore they can use that huge amount of information to develop new systems. And we don't have that type of database at the present time. And therefore that's a problem. What I can tell you with artificial intelligence, data is king. If you have data, you can use artificial intelligence in multiple ways of dealing with that data. But if you don't have very much data, it's very difficult to use these systems. One of the problems we have in neurosurgery and surgery in general is we don't have huge databases that allow us to understand, for example, what types of operations are associated with the most amount of error or the most amount of poor outcomes. The airplane industry has all that data. And we have to develop systems to develop that data from around the world, for example.
can I get your email so that I can send you some of this data
Sure.
I'm working on,
Sure.
so I can get your opinion on it?
Yeah, I'll send it to you. It's on his website. Yeah.
Okay, good, great, thanks. Thank
Joe.
you, thanks a lot. Thank you.
I personally think the more simulators that can be developed, you know, I sort of think there are going to be a variety of simulators. There are going to be simulators, for example, that can be very effective at one particular procedure. Let's say third ventriculostomy. You know, there can be a simulator. The Neural Touch has that simulation too, but that may be one type. You may have other simulators that are for, let's say, medium operations that have less, you know, more complex, but not as complex, let's say, as certain other simulators like removal of acoustic neuroma and things like that. So, you know, there are going to be a variety of simulators that are going to be developed over a period of time. The issue is, can we get a system whereby either people can use those simulators on their computer, or there are centers developed around the world where individuals can go and train. I'll give you an example. Johnson & Johnson is developing a new operation for spine surgery. So it wants to, and new instruments for it. So it wants to have all this done in a simulated environment so that individuals can train before they actually do the procedure. And so, you know, you can see what companies want to do. They want to decrease the learning curve in a new procedure. And those are the types of things that we're going to have to start thinking about too. How do we decrease the learning curve of residents and neurosurgeons if there's a new procedure? How do you decrease that learning curve so that you do not have the risk associated with patient risks associated with the early part of learning curves on new operations, new procedures?
You know, Doctor, you mentioned with Garnet Sutherland, we've done a couple of webcasts with him. Have you talked to him about collaborating with robotics? He's doing a lot of robotics, right?
Right.
Is there kind of commonality with your what you're doing a little bit?
There's some commonality. The issue about robotics that I find difficult is that if the robot is an interesting situation because it can do things more accurately. But the problem is, if you get a problem with the robot, in other words, let's say you get bleeding, you have to move the robot out. And suddenly the human comes in and deals with the problem.
Mm-hmm.
You see the problem we have there?
Mm-hmm.
So every time there's a problem, the robot has to be moved out so that the human can come in and fix the problem.
Okay.
There's an issue in my mind about that.
Mm-hmm.
Now, for very simple procedures, let's say a biopsy, perfect. The ROSA can be used, other systems can be used for that, no problem at all. But if you talk about complex operative procedures, you know, there are some issues related to robotic surgery that I find an issue. Yes, we moved together a little bit in the sense that, for example, some of the machine learning systems provide other types of information than the robotic information, for example. But the Da Vinci robot, for example, in prostate surgery has been used a lot in the general surgery to do various types of experiments, etc.
Mm-hmm.
So the question is, how do we, do I feel in the future that robotics will be a very important aspect of neurosurgery? Yes, I do. But I do think they'll be integrated into an intelligent operating system in the operating. They will be integrated with intelligent instruments. And so the question is, we have to develop all this together, the robotics, the intelligent instruments, the instruments that, for example, are the systems that prevent or tell you that you may be associated with an injury. The other thing that I will tell you as surgeons, and you all know this, is when you watch a student doing a particular operative procedure, for very much of that operative procedure, that student may be functioning very well. And then suddenly an error occurs. And the question is, sometimes that's quite difficult to predict, that the person is going to suddenly do that particular movement of an instrument, for example, or non-controlled movement of an instrument during the procedure. And the questions are, how do we train the student not to do that? And so the simulating systems may be of some help in that situation. I'm not downgrading, you know, Garna and I are good friends for sure.
Okay.
But I think there's a way of integrating both systems together.
Very good. Okay, Leonardo Abril, you have a question you want to ask the doctor? Go ahead, Leonardo.
I have a question, Mr. John.
The best greetings for everyone. Thank you very much, Professor Del Mestre, for this amazing lecture. It's very interesting to see your work, and not only your work, the results of your work. I completely agree with the simulation training because I think it's not just, I mean, the target is not to supplant or replace the natural anatomical training for residents and for young physicians. It's to maybe better like a complement or an extension or expansion of the neurosurgical training, because sometimes the mistakes in the operation rooms are related with hand skill mistakes, but most commonly are related with mental skill mistakes. So this kind of training help you to enlarge your acknowledgement, to repass your acknowledgement, or to make like a mental mechanism to avoid mistakes. So on first time, thank you very much, because your interest and your work is very interesting. I completely agree with this. But I have a question. How do you work together with the engineers? I mean, the programming engineers, or I don't know, graphical engineers, but how do you work together with them? Because they are not physicians, and sometimes they don't understand what kind of things we are looking for.
Well, what I can tell you is that if you're working with developing a simulator, I've developed a number now. If you don't have not moment to moment, but at least week to week interaction with these individuals, they tend to not produce what you want to have produced, because they don't understand the complexities. For example, as Manuel said, they don't understand the issues associated with haptics and how important haptics are. And therefore, their way of looking at things is a very, let's say, mathematical type of situation. Can we deal with the mathematics of that particular situation? And is there a way of getting around the fact that you can't actually get the real tactic, the haptics, but play with the instruments to see if you can, and play with the equations to see if you can. So it's very, very important for neurosurgeons to be actively involved with the engineers to make sure that you get the product that you want to have if you're going to be involved in developing it. And the way we've worked with the National Research Council predominantly when we were involved in developing the VR NeuroTouch, and that was relatively successful. However, we've also had experience where if you don't have input, you sometimes get a product that doesn't exactly fit what you would like. And when you try to validate that product, that's one thing that we haven't talked about very much here, but when you have a simulator, what you want to do is you want to put individuals on the simulator from various levels of expertise. Let's say from medical students all the way up to experts. And then what happens when you do that is you can say, are you able to differentiate these groups? Now, the other thing I will tell you, which is a problem, is when we were looking at neurosurgeons, actual neurosurgeons, 17 from 3 different countries, and asked them to do a simulation, surgical simulation on a simulator, brain tumor removal. We had a fair amount of variability in the way these neurosurgeons performed. And so some neurosurgeons seem to have abilities, technical abilities, that are quite different than others. And it's difficult to understand exactly what that means. What we also have done is we've done a trial where every medical student who was applying for neurosurgery in Canada was tested in our simulation. And what we found was there was about 25% of those medical students who were coming for the first time to do a simulation were better than second-year residents. The vast majority of those individuals were just average. And then there were about a third, or about 25% of those individuals who had poor bimanual dexterity. And they were poor in most parts of it. So again, if you're a teacher, you can have the experience of watching a student operate the very first time, and you know that that individual has good skills. And you also have experience, at least I have, where you work with a particular student over multiple years, and it's hard to get that student up to a level of competency because they just don't seem to have those technical skills. So there may be ways of helping those individuals. So in the airplane industry, if you want to fly a 747, guess what they do? They put you in a simulator right away. And you know what? 40 to 50% of all the individuals are rejected from that simulation. Why? Because they have hundreds of thousands of people who have gone through that simulation. And they know that if you don't reach a particular level of performance, it's going to take much longer to train you. They may not be able to train you. That costs a lot of money, so they just reject you offhand. So that's how they work. That's how they work.
John.
Yeah, go ahead, Manuel.
To Professor Del Maestro, and this Sunday, John, right? I have a lecture. I'm gonna show the models I am making also. So it's gonna be very good if you can assist, you can give your opinion, and who knows, we can work together in near future. You can see the models we are making. And something very important is remember that you know better than me, the plane don't bleed. It's something important because I play flight simulator, for example. It's something important the pilots do, but they don't. In the simulators they don't have feeling, sensation. They have all the mechanisms, all the buttons, but they don't have sensation, and it's something we need to work on that.
Yeah, that's incorrect in the sense that the airplane simulators, you can come to CAE in Montreal and you can do one. They have very good simulation of their hand controls. That's very, very important to them. And what I can tell you, for example, is one particular system is over the last number of years, what happened was that the pilots wanted to bring the plane down so the individuals who were on the plane did not get any sort of sensation of being bumped. And when they looked at all that information, what happened was when they were doing that, it actually caused the planes to move to one side or the other on a reasonable number of occasions. So they had to redo all their training to prevent that from happening. So all I'm saying is that the pilots have a fair amount of ability related to how they move their machines and all that kind of stuff. So they use that too. The other thing is they have about 500 things that can go wrong with the plane. Right, 500 things can go wrong with a major airplane. So the pilots have to be trained on all of those 500 things.
Hey, Ike, do you have some comments you'd like to make? Or?
Yeah, I think Manuel is barking up the wrong tree. Manuel, the thing is, it is not important for, as a surgeon, I don't think the sensation as such in a simulator is very important. What is important is to have a virtual reality, a 3D anatomy feeling, and that's enough. So after you've done enough surgery, you probably figure that out. So a sensation, as he said, I mean, I would always believe that once a surgeon gets to be easy, which means if you're driving a car, you get to be easy after some time. So for example, if I'm doing an aneurysm or if I'm doing a bypass, after 10 years or such, my hands are going to be much more easy than a guy who's starting it off right now. So I always used to believe that an EMG needle in one's key muscles would easily differentiate a novice from a master. I always tell my residents and my fellows that it's amount of force. I've told you that as well, Manuel. So the more force you put in, you're going to be a novice. You are a novice. So whether you operating an aneurysm, I don't know about spine, but whether you're operating an aneurysm or a skull-based tumor or anything, you need to be very, very gentle about it. So sensation is not really important. Sensation is something that you develop with experience. So you should not look into your simulator to get all that. And if you try and get all that, you're going to undermine the importance of a simulator. This is something that you should be using it for another another level of understanding.
Thanks, Dave.
Yes, but for example, Professor, you have the experience already. You can clip the aneurysma even without seeing it with the blind eyes. But for the young neurosurgeons, in the way we need to, because remember, we need to work with the sensation, because for us, we still are making the step-by-steps in our mind. Because for you, you have the experience, you made hundreds of aneurysma or glioma, but remember, it's not the same for young surgeons or young neurosurgeons, because the way in the training in the young neurosurgeons is, as I always say, anatomy 70%, and 30% is know how to treat the tissues, how to move the vessels, how to move the dura, how to move the arachnoid. But in our way,
Yes.
until we get to the level of your experience, we need to know how to deal with that, and remind and repeat in our mind before doing it. So the best way to do it is working with tissues, because otherwise, if we are as young doctors, if we are working with simulator without the feeling, without the sensation, when we go to make a surgery, you're gonna be the first one to gonna say, hey, hold on, slow, because we don't know the sensation, and we're gonna rush because, it's what I think.
Excuse me, can I ask a point?
Go ahead, comment.
I would thank Professor Rolando for your best innovation simulator, and I want to describe the point of Dr. Manuel in another way. I think Dr. Manuel's opinion about sensation or feeling that Dr. Leip described about it, it is related to behavior pattern of material. You know that the brain is a bioviscoelastic structure, and I think one of the biggest challenges in artificial intelligence simulation that Professor Rolando implemented in his innovation is how to interact between the instrument and tissue. You are giving the skills to the residents by this important device, okay? But for example, when you cut with a blade, for example, resect a glioma tumor, you want to have the best real imitation in your model, because you are giving the skills to hands of the residents. Then you should implement the thermal reply and response of the real brain to this device, to this simulation. Response to thermal shock, response to force, and etc. I think the point of Dr. Manuel is related to this behavior of material, bioviscoelastic, that elasticity is changed with time, and response to Cotter, to the thermal resection. And I wonder about this point, because I think maybe this point will be a pitfall for this simulation, because in giving skills to the hands of the resident, maybe we make mistake, because this imitation should be as real as possible to imitate the tissue response to this problem. Thank you very much, and I appreciate if you reply, sir.
Okay, thank you.
Thank you.
Well, what I can tell you is that the advantage of the simulator is that we can get these large numbers of metrics. So we can find things that you have never thought were important. For example, when we looked at machine learning, one of the 6 major metrics that we found was deceleration of an instrument.
Yes.
Now, have any of you ever thought about deceleration of an instrument during an operation? Well, that's a critical metric, because how you decelerate an instrument as you get near something important is critical to how you deal with that. So when Manuel is talking about feeling, it's much more complex than that. Because when you feel something, for example, when you're going between, let's say, to give you an idea of my experience, I've done 6,000 brain tumors in my life. 6,000. So I have a fair amount of experience with gliomas. That's all I did. So what happens in those situations is that when you begin to learn this script, that you, by feeling, you know when you're going between, let's say, edematous tissue and, let's say, tumor, et cetera. Now, you're not perfect any way, shape, or form, but you certainly get better with time. You certainly get better with time. The question is, could I have learned that with a simulator without having to go through hundreds and hundreds of cases before I sort of understood the importance of that particular aspect of things? Second, there is no question that learners generally use more force in the simulations. So could we not teach the learner before he goes into the operating room to decrease his force application? That seems relatively straightforward. Why do you have to go into the operating room as a learner and have these high forces that you use when you're using your instruments? If we could teach the learner before he went in the operating room that this particular level of force is what an expert uses, not the force that you're going to use. Because you've never experienced that force. You don't know how much force to use. Second, how do we really know how much force we are using during an operation? How many newtons of force are we using? It's physics, right? It's all physics. How much force are you using while you're touching an instrument and using an instrument to touch a tumor or a blood vessel or an aneurysm? What's your answer? Do we have answers?
The answer, yes, the answer is extracted from the reality of the tissue, plasticity and elasticity of the brain.
I agree. But then we
Yes.
have to have a number. We have to quantitate it. What is the quantitation of the number? I can give you that quantitation in the simulation. I can't give you that quantitation in the operating room because I can't measure it. I can't measure how much force you're using while you're doing a tumor in the operating room. Okay.
The elasticity of these portions like dura and etc. are in tables, yes? Experimental tables.
Right. All I can say is, if we can get to the idea, think about it in this way. For 2,000 years, people worked on the idea that the sun was not the center of our galaxy. Well, it was the Earth, right? And they had very, very beautiful sort of models where the planets rotated as they went around in various types of shapes and sizes. For 2,000 years, that occurred. And the models are very good. The models were very good. They could identify where Mars was, et cetera, in those models. But then Copernicus comes along and he says, no, there's a simpler model. And the simple model is that the sun is the center of the solar system and all the planets go around it. So suddenly what happens is, when you have that quantitation and you could do that, and people then were able to quantitate exactly what was happening and didn't have to use all these extra sort of little models that they had to put into the first model, then that quantitation allowed the whole system of physics to develop and just break open like crazy. And so that quantitation system allowed physics to go ahead where medicine stayed behind for 200 years. And the reason medicine stayed behind for 200 years during that time period is we did not quantitate, but physics did. So all I'm saying is, if you can quantitate behavior, if you can quantitate, for example, Manuel has talked about, for example, anatomy. I agree, anatomy is super important, but why can't we use anatomy in a simulated situation? You can simulate anatomy easy to simulate anatomy. You just have to develop the simulation for an anatomical structure, like the cerebellum, like the spinal cord, like whatever you want. It's not difficult to do the anatomy. What's more difficult is to put a tumor in it, which has different bleeding and has all kinds of other things. So it's just, we just haven't moved far enough yet. I'm not being critical of anybody. I'm just saying that if we're going to move forward in the future, we all have to look at it in a different way. We have to be able to quantitate what we're doing as surgeons, to understand how we operate, what expertise really is, and then try to teach our students before they go in the operating room and potentially damage patients, how to get some of those skill sets. For example, in our experiments, it looks like it takes a student about 2 years to learn how to use their left hand properly when they're using a sucker. 2 years. That's how long it takes them. Why can't we just train that in the simulator? Why can't we train it in the simulator? I'll give you one more example that I think is instructive. There was a resident in Canada that got sick during residency. And for 2 years, that resident could not operate because of the sickness. I was then asked to assess that resident, happened to be a third-year resident. I was asked to assess that resident before the resident went back into the program. When we assessed that resident in the simulator, that resident was operating at a 1 first-year level. So during that 2 years, that resident had lost what looked like 2 years of ability. We hadn't tested that resident before, so I don't have exact information. But what all I can say is, when we tested that resident, the resident was now like a first-year resident. So then what we did is we put that resident in the simulator for a month and test and train that resident on the simulator for a whole month to try to get that resident back to a third-year level. And therefore, when that resident went back to be into the residency program, that resident was put into third year rather than first year. And the surgical instructors felt that that resident was working at approximately a third-year level, and that resident graduated and is now a neurosurgeon. So we have abilities to use these technologies to help people who have problems. So there are multiple ways that simulation can be used, and that just happens to be one.
Thank you.
Okay, very good. Go ahead. Any more comments, questions? We're making you work today, Doc.
Well, listen, I have no problem with working. I have no problem at all.
Most neurosurgeons don't.
Yeah, I have another one. Another one is, for example, when we are using drills, because in this simulation, we cannot use drill. And it's something very important because, for example, in the model we're trying to develop, we make the, after you use the drill, you have the auto block, it's gonna stop. After when you're going through the skull, gonna stop when you go to the tabla interna. Because know how to drill with the Hudson or with the automatic drill, it's something you need hand skills. You need hand skills. And it's something, what I think, it's impossible to do it with the simulation because the skull have resistance. And it's something you get used to this resistance in the skull after drilling several times. This is one of the examples.
Well, what I can tell you in our spine simulation, for example, anterior cervical discectomy infusion, the third part of that is drilling. So the individual actually has to drill off the osteophytes. And so we, for example, in that spine simulation certainly is available. We have a number of papers on that. And so there's no reason why you can't use simulation as far as drilling is concerned. You can certainly do it. And you can get information about how much force is being used and all those aspects from it. So I don't think you should think of the simulators we have now as any type of a final model. We are starting, as I mentioned, 30, 40 years behind the airplane industry. We have obviously artificial intelligence that they did not have at that time. But, think about what the future is going to be. And the future is going to be, so different than it is now. And what we have to do as neurosurgeons is think about what is the future and how do we get there? And how do we get there to help our patients get the best possible outcome and help our students?
Absolutely, and please, I don't want to be like the strong in the shoes. I don't want to be negative. Absolutely, I'm just giving my opinion, comparing with the experience I have working with simulators. This is just like that.
Sure. No, listen, I think we have to use multiple different systems. Immersive learning does not only involve virtual reality. It involves cadavers, it involves all kinds of different things. But that's all immersive. We're just virtual reality, just one part of a very large immersive type of learning program. We're only one little part. The question is, are we the most important part? I don't know. We'll have to find out in the future about that. But it allows us to at least begin to get quantitation. And all I have to say is, if we can quantitate what a surgeon does when he does something in an excellent way and when he does something in a not so excellent way, we can hopefully train surgeons to do it more in an excellent-like way rather than a less excellent one. I mean, that's all we want to do. Just train people to do it better, quicker, so you don't have to make so many mistakes.
The airline industry encounter a lot of skepticism when they try to train their pilots on the systems.
Very, very much so.
Yeah, it's the same thing. They went through a period of skepticism and no, this won't work. It won't be applicable. Now it's it's totally accepted there.
Well, the other thing I will tell you, one more interesting fact. You remember that Boeing 747s, whatever, went down. They had this problem. And so what happened in that situation was that if you were a large airline and had plenty of money, then you could train your particular pilots to deal with this problem when the head, the tip of the airplane was going down. So they all got trained. But if you were a smaller airline and it wasn't compulsory that your pilots get trained, they were not trained. They were not trained on the simulator to deal with that problem. So I had experience with a pilot who was in the back of one of these planes and had been trained. He was moving between one airport and another, and noticed that the plane's front was going down. And he knew exactly what to do, but he noticed right away that the pilots did not. So he walks to the front of the plane, knocks on the door, and says to the pilot, I know what the problem is and I can fix it for you because I've been trained on a simulator to deal with that problem. And he goes in, tells them how to fix it, and it's fixed.
Oh.
But those pilots, both of those pilots, or the group of the pilots that went down in the two planes, were never trained on simulators. And therefore they had no idea how to fix that problem. So that just goes to show you the essence of how it works in the simulation in the airplane industry. It actually works there.
Okay, very good. Okay, more comments or questions for Doctor?
Professor, may I speak?
Go ahead. Go ahead.
Dr. John Bennett, first of all, I'm wondering, first of all, when do you ever go to sleep?
After the show. After the show.
After the show is all. Anyway, thank you very much, Professor Janet Bennett. Now, I would definitely appreciate what Dr. Rolando is trying to put through. We do not mean to replace simulation completely, or for that matter, brain lab. We do not say that we do not go to the lab to whittle your skills further. The simulator can definitely cut away or sharpen or polish most of the crudeness that lies in a resident's hands or a newcomer's hands. And after that is done, he can go to the brain, the lab. He can hone his skills on the lab brain, because it's not available to everyone. We in a poorer side of the country, India, we do not have so many labs over here. A simulator will be the first thing that my students would like to go through and become sharper, become softer, become more polished, then go to the brain lab and do the anatomy and do it on the cadaver brain, and then go on to the human brain, living brain. Who stops there? Nobody is stopping you from becoming a masterpiece, becoming a master like Professor Ike Cherian. Nobody stops you from, even Professor Cherian would not stop you from becoming a master. He would love you to become a master, but then the steps may be a little bit easier if he went through a simulator. Then he went through a fewer available brains of the cadaver, which are not as many. And then after that, you can come to somebody like Professor Cherian or maybe Goel or someone, and then become more sharp and more soft and more brilliant. So it's not an anti-step. It's a very much in need, and it's very much needed in places where human bodies are not that much, that many, or the embalming or whatever the system. I've been trained in endoscopy in Germany. Nowhere else did I find, in Berlin, and nowhere else did I find that kind of a simulation, or for that matter, brain cadaver anywhere in the world. So I'm very much in appreciation in this part of the world. I do not know the rest of how do you do, but of course, a simulator, then a cadaver brain, and then a master to teach you. I think that would be the best way on for any newcomer. Mm-hmm. Thank you, sir.
Thank you.
I'd agree with that.
Okay. You know, one comment I'd like to make, Doctor, was something you said before about engineers working with the neurosurgeons. This platform of Zoom, to me, when I first saw it, I thought immediately, I said, man, this would be a great way for people from different sciences to communicate. And I encourage you to use it. If you ever want to do Zoom and to get neurosurgeons together with engineers, because logistically it's hard for some engineers to go to the OR. Do you find some engineers, are they going to the OR, or are they hard to get to the OR to learn stuff?
Very hard to get them to the OR.
Yeah.
Very hard.
Very hard, huh? Okay.
Can I speak?
So that will be an area we need to improve. Well, this platform may be able to increase communication outside the OR, but of course it can't affect it inside. But
can I speak to John?
Go ahead, Omar.
Thank you very much for Dr. Orlando. Good presentation for all, and Dr. Manuel and Dr. all professors. I first things I tell, like before, we have only conversation between us. After that, mobile, telephone, mobile, and now that why smartphone? The technology is very necessary for us. The technology is very necessary to us. Like simulator, like everything, we must do forward with artificial intelligence in neurosurgery. Like this, make less time before we can go walk. Now we go airplane. Now we can speak on all the airs in face to face. This is very good. Easy time, shorter time, more patient, less dangerous complication. Before anybody in a brain tumor have a CVA. Nowadays, no. Not good to go any complication of any disease in the brain.
Okay.
I think this must, but wait. We must make not all surgeons. The human oil is very nice, artificial. We are the creator. Allah put us in this earth as a creator. We must to make beginning more things, big newest things. We are the driver. Not the simulator and devices is the over us. We are over all the devices of all the world. We must to make more. Nowadays on Mars, before 1,000 years, who go to the Mars? Nobody. Thank you, Dr. John, for letting me to speak.
I'm just laughing. Rolando, did you understand the question?
Yeah, I agree. I think that, if you look at neurosurgeons as a group, Cushing developed the BOVI, right? And then other neurosurgeons developed the bipolar. We as neurosurgeons developed the neuronavigational system. Why shouldn't we lead in artificial intelligence? Are we not smart enough or something? Of course we are. We should lead. That should be our goal. We should lead surgery. And to lead surgery, we all have to work together and use all our combined knowledge to work all together. And one way we can use our combined knowledge is through artificial intelligence, through other things. Artificial intelligence is just a technique. It's not anything super special. It's just a technique. But we should use that technique like we use the BOVI, like we use the bipolar, like we use any other technique to help us do a better job. That's it. I must say I'm very happy to see all the people as far as participants. I think this has been a good discussion.
Oh, there's a lot of people watching too. There's a lot of people watching too on the internet. And one thing, I hate to keep pushing Zoom, but I'm not a neurosurgeon, and the community I find most receptive to this technology of video were neurosurgeons. And if you look on the internet and you objectively evaluate the Zoom communities, I think neurosurgery is number one, because they the community seems to enjoy technology and learning new stuff. I don't know what it is exactly, but it's an enjoyable phenomenon for me. So very good, Rolando. I won't take too much of your day.